And welcome to Explain, the virtual Blackboard lecture series. In this talk, we're going to discuss about simple limbal epithelial transplantation. I'm going to start off by enumerating the alternatives to SLET, the principle on which it works, and then take you through a very slow step by step of the surgical technique itself, which is the main focus of this uh, presentation or this talk, and talk to you about certain surgical tips and tricks that you should keep in mind. And in between, we're going to discuss a little bit about what are the ideal indications for this surgical technique. Now, before I start, I would really appreciate if all of you who are SLET enthusiasts who would really like to learn this surgery to please go through this review article, which is in the August issue of the Indian Journal of Ophthalmology. You can directly scan the QR code from the screen here and download a copy. The download is free and it talks about everything that I'm going to discuss in this talk, and in much greater detail. It summarizes the outcomes, talks about what are the possible complications, how can you handle them, and basically it's a user manual for all SLET enthusiasts. So please go through this paper. Like I mentioned, it's in the Indian Journal of Ophthalmology. It's a free download. It's available for everybody. Just find this article on PubMed or go through this link or scan the QR code and download the article. All right. Having said that, I'm going to use these two schematics that you can see on your screen here to describe the differences between the conventional approach of conjunctival limbal grafting or keralimbal grafting and of SLET. So on the left is a schematic which describes conjunctival limbal grafting, which was the original technique of limbal transplantation, and how SLET fundamentally differs from it. So on the photograph of your left is a schematic of conjunctival limbal autografting. Now, if you pay attention to it, you will see that it consists of two lenticules. There is one lenticule on top and there is one lenticule at the bottom. This is conventionally how this surgery is done. Usually the length in terms of clock hours of each of these lenticules is about 2 to 3. There are some papers which describe 2 clock hours, some papers which describe 3 clock hours. These are taken either from the healthy fellow eye, in which case it's an autologous graft, or it is taken from a living donor. All right. A variant of this technique where you transplant only the cornea and the adjoining limbus without the conjunctiva is called keratolimbal allograft. This is because when you are taking tissue from a cadaveric donor, from a corneoscleral limb, there is usually no conjunctiva in a corneoscleral limb in the way that conventionally corneoscleral limbs are harvested. So you can't do a CLAL or a CLAU because there is no conjunctiva in corneoscleral limbs. So that technique is called a KLAL or keralimbal allograft. All right. Now in a conjunctival autograft, you can see here that it consists of conjunctiva on one side and the limbus on the other side. Now this is a fundamental difference between CLAU, which I am describing on the left, and SLET, which I am going to be describing on the right side. In SLET, the transplanted tissue, which are these small bits, consists only of limbus. There is some misconception and some people would like to believe that SLET is a smaller form or an abridged form of CLAU, which is not true, because SLET does not contain any conjunctival tissue in the what is transplanted on the cornea. You can combine SLET with an additional conjunctival autograft, but the SLET procedure itself, when we are talking about SLET itself, we are only talking about limbus and there is no conjunctiva. So this is the first difference, important difference. The second is that the amount of tissue that is conventionally used in CLAU is, like I said, about 2 to 3 clock hours in each lenticule. So that into 2. and that is equal to about 4 to 6 clock hours of limbus is what is transplanted. So in the photograph that you see on your left, there's about between 4 to 6 clock hours of limbus that is being transplanted. So this is the second difference between CLAU and SLET. In SLET, we only transplant 1 clock hour of limbus. So these small bits that you see, if you add all of these bits up, then it makes about 1 clock hour of limbus only. So that's a very big difference. In SLET, we use only 1 clock hour of donor limbal tissue, whereas in conjunctival limbal autografts we use 4 to 6 clock hours of tissue. The other big difference is that the limbus in CLAU is placed at its anatomical location. So you take it from either the healthy eye, in which case it is called CLAU, or you take it from a living donor when it's called CLAL. The limbus is placed at the limbus, whereas in SLET, the limbal tissue which is transplanted is not placed at the limbus, but it is placed at the mid periphery of the cornea. And this has a very, very important role to play in how SLET works. It has a very important clinical implication, which I will talk to you about later. Another important difference is that there is usually a very large conjunctival graft on the other side of the limbal graft in CLAU. That is the conventional technique. Okay. So in CLAU, there is always conjunctiva, like I mentioned before, or CLAL, whichever you're talking about. And therefore, there is always some conjunctiva. Now, it may not be as broad as this, it may be much smaller, but in terms of arc length, it is the same length as the limbus. Okay. Whereas, like I said, in the SLET technique, there is absolutely no conjunctiva in the tissue that is transplanted on the cornea. All right. Now, because of the way that these transplants are performed, how does the cornea actually heal? So, when you do a CLAU or CLAL, what happens immediately after surgery is that the epithelial cells start to grow out, first covering the limbus and the peripheral cornea, and once these two growing sheets of epithelium overlap, then the epithelium starts to grow centrally, and usually in these convex heads of epithelium growing towards each other. And as these come closer and closer and closer, the epithelial defect finally closes. So and this is very well described in a lot of studies, particularly by Dr. Dua. And therefore, if you look at the cornea towards the end of this process of epithelial healing, what you find are what are known as these Y-shaped or X-shaped or V-shaped lines, which look like pseudodendrites. Okay, and that is because these sheets of epithelium, which have these convex fronts, have merged and covered the cornea, and therefore you have these lines towards the end. Now, it is very important to understand that because the way the epithelium heals in CLAU, the center of the cornea is the most vulnerable part. All right, because it remains the most vulnerable part because it heals the last. So the healing is always from the periphery towards the center, because that's how the epithelium grows. So initially the epithelium will grow out towards the periphery, and then it will start growing towards the center, and these sheets will eventually coalesce to epithelize the cornea, and the central part of the cornea will heal last. Whereas in SLED, this is very different. Okay, and to understand what is the fundamental difference, we go back to what tissue is it that you're transplanting. So in a conjunctival allograft or an autograft, you have to realize that there is limbus only on one side of the tissue. On the other side, you have conjunctiva. So the limbal cells, which produce the epithelial cells, can only grow towards the cornea, right? They cannot grow, and they can grow peripherally. They cannot grow to the other direction. Whereas in SLED, because these individual pieces only consist of limbal tissue and no conjunctival tissue, and therefore the importance of harvesting only the limbus and knowing the exact landmark of the limbus when you're harvesting the limbal biopsy is so critical in the success of SLED. So in SLED, what happens is that because these fragments contain only limbal tissue, the epithelial cells can grow out in every direction possible and from each of these transplants. Okay, so there is multi-directional growth, whereas in CLAU or CLAL there is unidirectional growth. So it can only be from the periphery towards the center, whereas in SLED it is from the center of each piece is in all directions. So what happens in SLET is there is an island of epithelium which grows out from all of these individual pieces, and that is why we keep these pieces in the mid periphery, so that the peripheral part of the cornea and the central part of the cornea have an equal chance of epithelialization from each of these sheets. If you had put these pieces at the limbus, then only the cells which grow towards the center will be useful. The cells which grow outwards will be useless. So what happens in SLED is that it is epithelium growing out of each of these pieces, which then coalesce to form these large continental sheets of epithelium. And because the epithelium is growing from multiple areas in the mid periphery of the cornea, the center of the cornea or the periphery of the cornea have the equal chance of epithelializing at any point in time. Okay, because cells are growing in both directions. So they are going towards the center as well as going towards the periphery. So the center of the cornea is no longer the most vulnerable point which heals the last. In fact, you could very well in SLET see that the center has epithelialized much faster than the periphery, and you can see maybe at 5 days or 1 week that there is a small defect remaining over here or remaining over here, but the center is completely epithelialized because all of these cells, there was epithelium growing from all of these directions towards the center. So because of this multi-directional growth, the center heals just as fast as the periphery. So if there is epithelium growing in this direction, there is also epithelium growing in this direction. So any random point on the cornea, whether it is over here or over here, has the same chance of healing at any given point in time. Now this is also very, very critical to the understanding of how SLET works. So another fundamental difference between the two procedures is the fact that in CLAU, many surgeons who do the conventional technique now use amniotic membrane as a scaffold. So they'll put the amniotic membrane first and then do the graft. Okay, or some people will do the graft and then put the amniotic membrane on top. That is also done. But it is not conventionally described, the use of amniotic membrane for doing conjunctival autografts or allografts. In SLET, however, right from inception, it is absolutely imperative that we use the amniotic membrane, and the amniotic membrane serves many purposes. What are the purposes it serves? One is that it serves as a scaffold for the epithelial cells to grow on. So it's a very good membrane on which epithelial cells grow very fast. So the epithelialization is faster. Number two is that the spongy side of the amniotic membrane. So when you lay the membrane down, it has a basement membrane side which is on top, and it has a spongy side which is at the bottom. The spongy side basically fills in the irregularity of the corneal surface. So it's like a Tetris matching. So when you remove the panels from the corneal surface, there is a lot of irregularity which is filled in by the spongy side, and therefore the corneal surface becomes more regular. And the third and the very important function of the amniotic membrane is that the periphery of the membrane, till it gets dissolved, which takes about 4 to 6 weeks, keeps the conjunctival tissue which has been recessed at bay. So you have about 4 to 6 weeks of time within which the conjunctiva is not going to grow in, because there is the amniotic membrane which is preventing it from coming in, and the limbal tissue gets this huge amount of time to completely epithelialize the ocular surface. So obviously there are certain advantages of the SLET technique. Because of the fact that you're transplanting only limbal tissue, the epithelialization of the cornea is much faster than the conjunctival limbal grafts, where there is only unidirectional growth, whereas in SLET there is multidirectional growth. The amniotic membrane also plays an important role as functioning as a scaffold on which the cells can grow very fast, evening out the surface of the cornea and preventing and keeping the conjunctiva at bay. In CLAU, while the conjunctival grafts where the limbal grafts are prevents the conjunctiva from moving in any further, there is no protection medially and laterally. And therefore, if you, though for those surgeons, and if you've seen outcomes of conjunctival grafts, you will see that many of these eventually heal with a pseudopterygium that comes in medially or laterally. Okay, and that is because it does not provide any protection in these directions. Whereas because of the use of the amniotic membrane in SLET, it provides a 360-degree protection against the conjunctiva coming in till the surface has been completely epithelialized by the cornea. So the differences are that SLET, the transplant contains only limbus, whereas in CLAL or CLAU, as the name suggests, it consists of the conjunctiva and the limbus. And the unidirectional, multidirectional growth, the use of the amniotic membrane, and the fact that any random point on the cornea has an equal chance of getting epithelialized at any point in time. Whereas the epithelial healing in CLAU or CLL is very, very predictable and is always periphery to center. It cannot be center to periphery because the grafts are at the periphery. And because of these differences, SLED becomes a technique where the epithelialization of the cornea is much faster than the conjunctival allografts or autografts. And from this also you can understand that the one disadvantage that SLET has over CLAU is the fact that because of the complete lack of conjunctival tissue, in those cases where there is a severe symblepharon, which also needs to be addressed, in addition to SLET, you also have to perform a conjunctival graft. Okay, so the main disadvantage of the SLET technique, I would say, is in the fact that it addresses only the limbal stem cell deficiency, not the conjunctival deficiency. This conjunctival deficiency, however, is addressed by conjunctival limbal autografts. However, you can easily combine a SLET with a conjunctival autograft, and here you are not limited. For example, in CLAU or CLAL, you have to put the conjunctiva where you put the limbus, but in SLET, you do not have any such dependence, because your limbal grafts and your conjunctival graft can be independent of each other. For example, if the symblepharon is in this axis, if you are doing a conjunctival autograft, you have to put the conjunctival graft over here, because the conjunctiva and the limbus are yoked together, they are linked. But when you are doing a SLET with the conjunctival autograft, you can do your SLET in the usual way and just put the conjunctival autograft wherever the symblepharon is most severe. Alright, so having said these things and made these differences and the wound healing mechanism very clear, I am going to move on now to the surgical technique. So we always start SLET from by first performing the limbal biopsy, and before I go to the limbal biopsy proper, I would also like to make a few points about case selection. Now this is very important. The photograph that you see here is a perfect case for SLET. Why? Because you have a patient who has total limbal stem cell deficiency, you have a pannus that has grown completely over the cornea. You can obviously make out very clearly from this photograph that it's a wet eye with good luster. The lids look normal. We can assume here that the closure is complete. The eye is not dry at all. And these are the perfect preconditions for SLET. The other thing that you can notice, and this is very subtle and I want you to pay attention here, is that you can faintly make out the pupillary border over here in this photograph, which basically means that the underlying stroma, the stroma under this pannus, is translucent, is not opaque, which means that if I can do the surgery properly, when the epithelial surface is restored, the patient will recover good vision and also good cosmesis. So therefore, if you can sum up the points that I made, I said that the best cases for SLET are those which have total limbal stem cell deficiency, that have a surface that is wet, that have lids that are normal and have good closure, and where the underlying stroma is relatively clear. It's obviously not completely crystal clear, but it's relatively clear. All right. And typically you would like to start off doing autologous SLET, which means that the other eye is normal and the donor tissue is going to be autologous and therefore at no risk of rejection. So if I move ahead, and I will now show you what the OCT of the same patient looks like. So if you see here, the OCT is also another way of finding out what the underlying stromal clarity is like. So if you see the OCT over here, you will see that the infrared photograph, you can very nicely make out the iris and also the pupil, right? And this is also a good indication that the underlying stroma is relatively clear, and you do not have to use an OCT for this. Any infrared camera will show you this, and that should be sufficient. But what the OCT also shows you in the line scan, and this is mentioned in the article also, is that it gives you an idea about the thickness of the cornea. So you can see here, this is a 250 micron bar, and you can see here that the tissue is about maybe at least 350 to 400 microns in thickness, which is good thickness. And so if there are any areas which are irregular in thickness or very thin, it alerts you to the possibility of that happening. All right. So having said that, we can now move on to the surgery proper. When I am doing a limbal biopsy, I am usually doing it under topical anesthesia, and therefore you will see that during the biopsy my illumination is only set in retro. It's not very bright. The patient has not been blocked in this eye. This is an adult patient. Of course, if you're doing surgery in a pediatric age group, then you have to, it's on a general anesthesia, but here it's an adult patient under topical anesthesia. So I usually use preservative free lidocaine and I spray that on the ocular surface first, and I just create a small bleb superiorly in the conjunctiva, and here again I am injecting preservative free lidocaine in this bleb, and I will create a bleb in this area. This bleb will allow me to lift the conjunctiva very easily and to start my dissection. So the purpose of this creating this bleb is to create a limbus based conjunctival flap that will help me in my dissection. So once I have attained a bleb of a proper size, I am going to take my Vana scissors and start creating this limbus based flap. Now another important thing that I want you to pay attention to here is that you should not rely on the identification of the limbus only by the pigmentation of the limbus, for two reasons. One is that, as you can clearly see in this image, the pigmentation extends from round about here to up to over here. Now this is obviously conjunctival tissue. So the pigmentation and these striate pigmentation that you see in many cases can extend beyond the limbus. So if you look at only pigmentation as the marker, then you will be mistaken into taking conjunctival tissue in addition to your limbal tissue, and that is, like I mentioned before, could be a reason why your graft fails, because there are no corneal epithelial cells that are going to ever grow out of conjunctival tissue. All right. So we proceed with the dissection, and here I am dissecting between the conjunctiva and the tenons, and I am going to over here, if you pay attention, that the extent of the dissection is only about 3.5 to 4 millimeters. So 3.54 millimeters is the measurement for about 1 clock hour of limbal tissue. All right. So you know that if there is a circle, the circumference of this circle is 2 pi r, and if you are going to divide this by 12, which is, you want to find out what is the what is the length of each clock hour. So if you assume that the radius is 6, right, so this two cancel out. So 1 clock hour is basically equal to pi, and pi, as you know, is 3.14. and so mathematically it's between 3 to 4 millimeters of tissue. So horizontally, this amount of dissection is going to be between 3 to 4 millimeters. Please don't take tissue which is more than this, because it's redundant and you are going to waste limbal tissue. It's really not required. A case of total limbal stem cell deficiency will be amenable to correction by transplantation of only 1 clock hour of limbal tissue, and not more than that. And that is the beauty of SLET, and that is why it is so advantageous compared to conjunctive limbal autografts or allografts, where you're taking so much of limbal tissue. So I'm proceeding with my scissors pointed down towards the limbus, and I'm dissecting between the conjunctiva and the tenons, and this is very important. So you try to take as little tenons as possible. So the same way that you dissect a conjunctival graft in a CAG, in a conjunctival autograft, when you are doing pterygium surgery, you also try to take as little tenons here. Here we are not going to use the conjunctival tissue per se, unless you are combining the SLET with a conjunctival autograft, but we are using this conjunctival tissue as a handle for proper manipulation. So once I am close to the limbus, I am just going to take a sponge and clean that area, and now start dissecting with a number 15 blade. Now why we use a number 15 blade is that because it is not very sharp. Okay, so it might sound counterintuitive to you, but the reason that we prefer a number 15 blade is that it is not very sharp. I would really not recommend using a crescent blade, because a crescent is very sharp, and because it is very sharp, you can easily go much deeper into the cornea or have a buttonhole. Use a number 15 blade which is very controlled. Some surgeons also prefer using the blunt side of the number 15 blade. So typically this is the sharp side. Okay, this is where the bevel of the blade is, whereas there is no sharpness over here. So some surgeons will, instead of dissecting in this direction, will hold the blade and dissect in this direction. So use the blunt side of the number 15 blade, so to have a more controlled dissection. So it is just sharp enough for you to do a blunt dissection, but not sharp enough that you will buttonhole or that you will go too deep. Now when you're doing the dissection, you obviously know that it's now started to bleed, and this is very important. These bleeders that you see, this bleeding line is the posterior boundary of the limbus. Alright. Now remember that when you're doing the dissection, you are actually reflecting the conjunctival flap. So even if you were thinking about pigmentation to be your guide as per where the limbus is, when you're dissecting, you can't actually see the pigmentation, because pigmentation is on the other side of this flap. Alright. So pigmentation is completely useless. First of all, because it's not present in every case. Second of all, because it can extend beyond the limbus. And third, because you can't see it when you're dissecting. So please understand the anatomical landmarks which will actually help you to identify and dissect the limbal tissue. This is very critical. Now once I've exposed this bleeding line, now I'm dissecting the actual very superficial limbal stroma. And here you have to remember that do not go deep. So we do not want stromal tissue in our dissection. There is absolutely no utility of taking stromal tissue when you are doing the dissection. Alright, we are only interested in the limbal epithelial cells, and therefore only a very thin sliver of stroma is enough. And you will see here, therefore I am keeping my blade very flat. Now this is critical. Now I continue my dissection, and now I am dissecting into the grey clear cornea, and this is basically, now that I have dissected enough. So if you see the anatomy of this tissue, now focus very clearly into this part of the dissection here. So this is the stromal area that I have dissected, and if you can look here at the reflected conjunctival flap, you will see that there is this area which has this whitish discoloration. This is the conjunctiva. Okay, and the area that does not have this whitish discoloration is the limbus. So when I dissect this tissue further, I will cut out from here and I will discard this part of the tissue. I do not need this. I am only interested in this tissue. So therefore, it is absolutely imperative that you understand the anatomical landmarks to identify the limbal tissue which you need for transplantation. And it is absolutely essential that in your limbal transplants you do not include any conjunctiva, because if you have a piece which has a bit of conjunctiva in it, there will be no cells growing out in this direction. So cells will grow out from all other directions, but not where there is a conjunctiva. So it defeats the whole purpose of doing a SLET. You might as well do a conjunctival limbal autograft. Alright. So remember the anatomy of the limbal tissue when it is reflected as you are dissecting, so that you can identify what you have to cut. This is also important, and some people ask me, but how important is it to dissect only the limbus when you are doing SLED? What if you get some conjunctiva? So it's like asking, what is the importance of the kidney in kidney transplantation? It is everything. This is the tissue that you are transplanting. So the success of your transplant depends on your donor tissue. If you don't take limbus in your dissection, how do you expect SLED to work? It's not going to work. Or it's at least every piece is not going to work. And that is the whole idea. So we dissect until the clear cornea. You will also see here that my nurse here is dropping drops of fluid, either BSS or RL, and that is helping in the blood which is oozing from this limbal capillaries to get drained off the surgical field, and that is helping in my dissection. Now I will always put a few drops of brimonidine to prepare my cases, both in the donor eye and the recipient eye. It really helps in preventing too much bleeding. Otherwise, when I was cutting the conjunctiva also, there would have been a lot of bleeding, which did not happen because this eye has already received brimonidine. However, the limbal vessels will always bleed irrespective of how much brimonidine you put, and you will see that in the recipient eye also. This happens because the limbus is also supplied not only from the episcleral plexus, but also from the major arterial circle of the iris. So there is supply to the limbus from inside the eye also. So the brimonidine doesn't really work on the source which is inside the eye. It only works on the surface. So those vessels blanch, but from inside there is still bleeding. That will always happen. So I am just releasing the edges now of the of this flap, so that when I am cutting the limbus off, I get the full dissected area. And now here I am going to cut through this part, so that I get only limbus in my tissue. So I have cut off the conjunctiva. I am going to discard this because in this particular case I am not going to do a conjunctival autograft. And then when you are taking this graft, remember that when you insinuate your blade, it goes all the way into the dissected flap. So don't undercut, okay? Otherwise you would have dissected limbus nicely, but when you're cutting it off, you may not. And also notice here that I am using a non-tooth forceps to hold the limbus and not a tooth forceps, because I do not want to cause any trauma to the very delicate stem cells that are in that area. And I'm continuing my dissection throughout the area that I have, the ledge that I have created, and this is the tissue that I am going to transplant. Now remember that this is very valuable tissue. Always keep a bowl of fluid ready. Don't overfill the bowl, just have a little bit of fluid in it. The tissue does not require a lot of fluid for preservation. You can also use MK media if you want, if you have it ready. It's not essential because you are going to use it in the next half an hour or so. And just keep a bowl of RL or BSS on your tray, and don't fill it up to the brim. Okay, it's not really necessary. Just keep a little bit of fluid in it, and just make sure that the limbus is floating in it and is not dry. So the limbus should not be stuck to the edge of your bowl. This is very important. And so there should be enough fluid that it floats, but there should not be too much fluid that you lose your limbal piece, because you are trying to, when you recover the limbus, you are going to look at it either through a naked eye, and it's very small, it's only 3 to 4 millimeters, or you're going to look under the microscope where there's a lot of reflection because your bowl is made of steel and you may not be able to see it. So the fluid also needs to be minimal. There should not be too much fluid in your bowl. And once you've done this, you take the speculum off and then move to the recipient eye. Now here again I am putting brimonidine just to prepare the eye, and I also want to make a point that this patient has received a few drops of brimonidine about 10 minutes before the patient was shifted into the OR, and therefore now 20 minutes have passed because I've also done a biopsy. So this is a very blanched eye. This eye is actually much more congested if you look at the preoperative state before putting brimonidine. Here I am working under full illumination, and I'm going to start the dissection now. Now for this purpose I usually start from the right side. So if you are because I'm right-handed, so if you are working on the right eye, in this case this is the right eye, so it's supero temporal. If it's the left eye, it's supero-nasal. That's because you always want to be in control when you're doing the dissection of the panels. These scissors, as you see, has one of the blades has a sharp tip, the other has a blunt tip, and this is specially designed for SLET. It also has markings. You can see each of these is a millimeter, so that when you're taking the limbal biopsy, you can measure that your biopsy is 4 millimeters in width, and you can do that exact measurement without requiring any additional paraphernalia or any other instrument like a caliper. I'm going to slowly insert with both blades together so that it makes a blunt spatula. It's like a dulk scissor, and I'm going to open it up. So I'm going to creating the space. Here the important difference is that I'm going subtenons. Okay, I've cut the conjunctiva and tenons together. So it's not like when you're taking the biopsy, when I'm going in between the conjunctiva and the tenons. Here I'm going beneath the tenons, and this is again a very important differentiation. I'm going under the tenons here because I'm going at the plane where the tenons inserts, and that's the plane at which the pannus inserts into the cornea. And I'm going to slowly create this space here by insinuating the blades of my scissors and slowly opening them up so that I can create the space. And from this superior right hand side here, superiotemporally, about 10 o'clock, as soon as I make this space, I'm going to keep going around 360 degree. Now this is very important, and like I said, as soon as you go at the limbus and you release the pannus, it will start bleeding. So it didn't bleed till now, but you can see that it has started to bleed again, because the limbal vessels will always bleed irrespective of whether you have put brimodine or not. And what I'm trying to do here is the same, repeating the same step over and over again. I'm going in, opening up that space, putting in the blades of my scissor and trying to release the pannus 360 degree first. This is very important. You should not dissect towards the center first. You should always release the pannus from the ocular surface 360 degree first. This makes the pannus mobile and allows you to lift the entire pannus of the corneal surface as one sheet. Otherwise it will come off piecemeal if you try to go in the center. Also, your chances of having an intraoperative perforation are much higher if you are dissecting towards the center rather than what we are doing here. Here the chances of perforation are very less because usually the thickest part of the cornea is in the periphery. So I'm going to limit my dissection only in the periphery right now and then slowly move towards the center. And as you can see, it is basically repeating the same step over and over again. Now you can, if you have too much bleeding and you're bothered by it, I am not bothered by it right now, but if you are bothered by it, you can stop at this point, do a gentle cautery 180 degree and then proceed, so that you have a very clear field and you're not bothered by the bleeding at all. Okay, that's up to you. Here it's not really bleeding much, it's just oozing a little bit, and my nurse is doing a good job of spraying fluid so that the blood does not collect as it is oozing, and then I can keep going and complete the dissection without having any trouble with visibility. And you can also see that I'm using the closed blades of the scissor as a dissecting instrument. So this scissor is very useful in carrying out the dissection because it combines the roles of a dissector and a scissor, and you can perform both roles together. So this is basically a long flanged modified Vanas or dulk scissors with one sharp tip and one blunt tip, and the blunt tip usually has the markings for measurement. And like I said here, as I'm releasing the pannus from the limbus, there is bleeding that is occurring from the surface, and you can, if there is too much bleeding, you can stop at this point, cauterize the vessels to improve your visualization before you complete the dissection. That's also fine. So you can go quadrant by quadrant, you can cauterize one quadrant, release another quadrant, cauterize that quadrant, and go so on and so forth. So what I'm going to do here is again, release the the panels that I am dissecting 360 and then complete that dissection first, and you can see as I am doing that, the panels has very easily lifted off from the cornea, and this is easiest in those cases where an amniotic membrane graft has been done previously. Now, after I have done this, I am going to just do a blunt tenotomy to release the tenons 360-degree around this dissected area. This is very important. You do not want the tenons to stay close to the limbus because it will hamper your laying down of the amniotic membrane. And if your tenons is all, you have to create a Bay sclera. If you do not create a Bay sclera, then your conjunctiva will come back very fast because your amniotic membrane that you put will degrade much faster, and the conjunctiva will just come back much faster, and therefore, like I mentioned before, that lead time that you have is less. Now, after I've done a gentle cautery and stop the bleeding from some major vessels, what I'm doing here is clearing all the fibrous tissue by gently peeling it off with these non-tooth forceps. And usually there is this area, this gutter at the limbus where there will always be some fibrous tissue, okay, and this fibrous tissue needs to be peeled out, so that your cornea looks nice and circular when the cornea reepithelizes. Otherwise, it will look a little bit smaller than the other eye because of this about 1 millimeter of granulation tissue that remains in the gutter that was formerly the limbus. So, removing this fibrous tissue from the gutter of the limbus is very important. After that, I also do this very important step, which is removing a frill of tenons, about 3 to 4 millimeters of tenons, 360-degree. This helps because it basically makes the conjunctiva fall back. It creates enough room to tuck in your amniotic membrane. It creates enough room for you to put your bandage contact lens without it getting crumpled. And especially in children who have tuna burns, a lot of tuna often gets retained in the tenons that you can't see when you're doing the dissection, okay, because it's incorporated within the tenons. But if you prophylactically remove this ring of tenons, then whatever little bit of tuna is remained but you can't see right now also gets taken care of. But even if if it's a non-tuna burn, I will still remove this 3 to 4 millimeters of rim of tenons or 360 degrees because of the reasons that I mentioned before, that it allows the conjunctiva to recess and fall back, create enough space for the amniotic membrane to be tucked in nicely, and also therefore delays the re-emergence of the conjunctiva towards the limbus, because the amniotic membrane stays over there for a longer period of time. After I've done this, I'm just kind of cleaning the surface, doing a little bit of cleaning up around. I see some tenons still there superiorly and I want to get rid of that attachment. If for some reason you are scared and you think, oh, am I cutting the rectus, you can always take a muscle hook and hook the rectus and make sure that you're only cutting granulation tissue or tenons and you are nowhere close to the muscle. These are very familiar, this is very familiar territory for me. I have no such insecurity and I know the difference when I'm cutting tenons versus muscle, so you can see that I'm quite nonchalant about it. Again, here I'm doing a little bit of cleaning up with the cautery, making sure that there are no bleeders by the time I reach transplantation, and this is always a wet cautery, remember that. Now I'm going to put the amniotic membrane down. Always remember that the amniotic membrane is always put basement membrane up or stromal or sticky side down. There is no other way of putting the amniotic membrane, and there is no need to put two membranes. One membrane is enough. So I'll fold the membrane, make sure that it is distributed properly, that there is enough on all sides. So make sure that it is well centered. It's not sloppy, that it's too much on one side, because then when you get one side attached, you realize that there's not enough on the other side. And now putting one drop of fibrinogen first, and you see here that I'm putting only the component of the glue on the corneal side, and I'll tell you why. And then I'll put a few drops of the thrombin solution here again on the cornea, and it doesn't run because as it falls on the thrombin it gels. And then I'm reposite the amniotic membrane. I use my curved tying forceps to kind of massage out the glue. So when I'm doing this massaging, as you can see in these movements, with the movement of my forceps, the glue also gets spread in this direction. So I don't have to put glue on this bare sclera, I just put it on the cornea and then spread it, massage it, so there is no excess glue that is kept. Again over here I'm doing the same for the upper part. I'm going to, I've lifted off the amniotic membrane, folded it, I'm cleaning it up, putting the fibrinogen component of the glue, spreading it on the cornea, and then I'm going to take the thrombin and I'm putting a few drops of the thrombin component on top now, and as I put them the glue gels, and putting the amniotic membrane and then spreading with the curved tying fork. You can also use a blunt spatula like an iris spatula to do this, and as I am doing this the glue gets spread in this direction. Okay, and I will also make sure, now I'm taking a blunt spatula and doing the same, that the amniotic membrane has gone all the way under the conjunctiva as far as it can go. It is not crumpled in any area and it is not falling short, you know, so it should have gone beyond the conjunctival edge 360 degrees. There should not be any area where it has fallen short, because it can fold. And whatever is redundant, whatever is excess, I'm going to take my varnish and I'm going to cut it. You can see here there is a little fold of the membrane here, so I am going to clean that area, reapply glue and make sure that the amniotic membrane goes nicely beneath this conjunctiva over here. So that's what I'm doing here with my spatula. So this is the last but more critical part of the surgery, and I'm going to quickly show you how I cut. Now I have the limbal tissue here. I have lifted it with a non-tooth forceps with my left hand. I'm raising it slightly from the surface, taking my scissors, making sure that the blades of my scissor nicely pass the tissue. So the blades, you should not put tentative cuts, okay? So you should not hold the scissors so that only the tip of the scissor is over here, because then what will happen is you will only cut a part of the tissue and then you have to cut again, and that macerates the tissue. So make sure that the blades are nicely across and well in advance of the tissue, and then you're cutting with somewhere in the middle of the blade of the scissor and not at the tip. This is a very common mistake that people make. Then you get a single piece that comes off and you put it over there, and then you keep cutting this. It is absolutely imperative that when you put the pieces down, they're epithelial side up, they are not stromal side up, and here you can easily make out from the shiny epithelial surface, and the stromal surface is always whiter and rougher because of the stroma on the other side. So once I have cut the pieces to the shape, and I am typically trying to get triangular shapes, but in the beginning when you are cutting these tissues, it doesn't really matter what shape. In a tissue that is about 3 to 4 millimeters in length, or 1 clock hour in length, that tissue we typically will divide into 6 to 8 parts. So 1, 2, 3, 4, 5, 6, 7, 8. That's the ideal number of shapes that you want. So if this is how the limbal biopsy will typically look like. We are trying to make small triangular pieces out of these, and if you count the pieces here, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10 here. So between 6 to 10 pieces is the ideal number. It should not be more than 10, because then it macerates the tissue, and it should not be less than 6, because then you have very chunky pieces that are difficult to manage. So moving on, I'm going to use a wet tipped spatula to now spread the tissues. Make sure that the tissue bits are never completely dry, and I'm going to put them in the mid periphery like I mentioned before, and making sure that all these pieces are epithelial side up. 1 drop of fibrinogen in the middle, and then 1 tiny part of a drop on each of these pieces. Once these drops have been placed, I'm again going to take a spatula and make sure that I spread out the fibrinogen, which is the thick part of the glue, evenly over the corneal surface. This is very, very important because when I put the thrombin, which tends to run, I don't want it to run too much. I want it to fall on this bed of fibrinogen and gel immediately. So now I'm putting the thrombin component, and you see that it doesn't run because there's a bed of fibrinogen already on the cornea, and you just put some in the center and a little tiny bit over each of these pieces, and that is usually enough. So you don't need to overdo it, and you will see the glue gelling. Wait for about 1 minute by the clock, and once you can see this whitish marks which indicate that the glue has gelled in place. So if you can see these whitish kind of marks over here. That's basically an indication of the glue gelling. It's kind of spidery, and that tells you that the glue has gelled in place. Just wait 1 minute by the clock, that is enough. And once that has happened, the last step of course is to put a bandage contact lens on the eye. Now this is the end of the surgery proper, but this does not mean that your final step is over. If you have used too much glue, or if your glue has run a lot, you have a spurting of glue when you are applying it, you will have these the glue sticking in the periphery to your speculum, okay, and that is very, very dangerous. So you will have clumps of glue lying over here or lying over here, and these can be connected to the glue sheet that is there in the cornea, So if you try to peel them off, you might actually start tugging at the sheet of glue that has the transplants. So make sure that when you are removing them, you cut these strands and you don't peel them when you are removing the speculum. This is the key and very final. So I have Vanna scissor in my hand, and as I am removing the speculum, if I see a strand of glue attached anywhere to the speculum, like over here you can see that there is some glue over here, I am not going to peel it, I am not going to pull at it, I am going to take the Vannas and just cut at it, so that I don't pull at the sheet of glue. And this finally is the end of the surgery. And this was the preoperative appearance of the ocular surface when we saw it before surgery. I showed you the photograph and I showed you the surgery, and this is the post-operative appearance after 6 weeks. And you can see how nicely the cornea has cleared up. You can see the individual pieces exactly where we placed them. None of them have moved from their position, they're all there. And you can see the obvious improvement in the corneal clarity, and you can also see that the amniotic membrane here, the conj is still way back where we left the amniotic membrane, and you will see remodeling over time. You will see that the conj will move closer over time, and this will happen, but this is typically how it looks at 6 weeks. Very rarely do you get primary failure in SLET, and if you have a primary failure, which means that your amniotic membrane is gone or your SLET pieces are gone or it didn't epithelialize to begin with, then you should really think of some technical issue with your surgery, and you should consult an expert and talk about the case or review the video. Usually all SLET is 100% successful at 6 weeks. That is the rule. It is 100% successful at 6 weeks, and the typical recurrence in SLET is a pseudopterygium, which recurs if there had been a severe symblepharon preoperatively, and that was not addressed by doing a conjunctival autograft. And how we combine SLET with conjunctival autograft is going to be the subject of a different talk. But please go through the article, and it gives you wonderful illustrative examples of when a conjunctival autograft needs to be combined with SLET, when a conjunctival autograft needs to be done alone and a SLET is not required, and what happens if you don't do a conjunctival autograft in addition to SLET when it is indicated. Alright, and if you look at the OCT also post-operatively, you can see this very shiny white line over here. That's the AMG, and you can see it throughout, and therefore it shows you that the epithelium grows over the AMG, and you see how well nicely incorporated it is, and you can see the nice hyporeflective epithelium on the surface, which indicates that the epithelium is corneal or limbal in origin and not conjunctival. As you saw preoperatively, it was hyperreflective, and you can see that in both the scans. And obviously you can see that in the central area there is a little bit of flattening of the cornea because of the loss of tissue during the burn itself, and there is some haze in the center. You will actually be surprised to what extent this haze clears. The amniotic membrane itself clears and becomes more transparent over a period of about 6 to 9 months, and usually by 12 months or 1 year the amniotic membrane is completely transparent. So it's only a matter of time. You have to hold your breath. Please do not try to do SLET without the amniotic membrane, because it is critical to the success of SLET. However, amniotic membrane itself by itself is not everything. So it is very well documented, and if you read an ophthalmology paper, it says that when the pieces fall off, if the technique is wrong and if you only have the amniotic membrane on the surface, then there is 100% recurrence. Okay, so the amniotic membrane itself is not sufficient, but the combination of the limbal transplant and the amniotic membrane is a fantastic combination that gives you excellent, reliable, replicable results. You can restore the corneal transparency in the severely damaged eyes and restore perfect vision, near perfect vision, as good as possible in these patients. And there are so many ways in which you can improve the visual acuity in these patients post-operatively by doing, giving them contact lenses, which is the easiest, and even refractive surgery. I have had patients who have had PRK after Sled and have done very well. All right. So just to summarize, we talked about the differences between SLET and conjunctival limbal autografting or allografting. I told you why it is important to harvest only the limbus, that this is solely a limbal transplant. It does not have any conjunctiva in the graft. I told you how the wound heals after a SLET surgery. We went through the surgical procedure very slowly, step by step, and I hope that if you have any confusion, please see the video again. It's a relatively unedited video which I stopped multiple times trying to show you the important steps. If you have any queries, please feel free to comment in the comment box or send me a message on WhatsApp or email, and I will be happy to take those queries as well. And we also discussed in between about what are the preoperative considerations that you need to look for in SLED. I mentioned about the eye being wet, it being total LSCD, the underlying stroma being relatively clear, and that the eye should have good closure. Please remember these criteria. Do not become too aggressive or too adventurous and try to do SLET in dry eyes or eyes with lack of thalamus or those who have partial LSCD, because those are not the indications of doing SLET. Use it wisely. It is a very, very powerful weapon. It works wonders for patients, and use it for your patients for their benefit, and you'll get fantastic results, and these will be the happiest patients that you have. Also, like I mentioned before, please read the article that I showed you before. It has the answers to most of the questions that you're likely to have, but if you still have some questions, feel free to put them across to me and I'll be happy to answer them for you. Thank you so much for your attention.